everybody. It is just on 12 noon. We've had a couple of, not teething issues, but just a couple of issues because of, we initially were going to do this meeting on Teams. So I have some people in a Teams room who I need to transfer across to here, which requires a little bit of fancy footwork on my side. And I also want to just add Ushma, who is the co-director of SIDA and co-hosting the meeting, and make her a co-host so that she's able to help me with admitting people into the waiting room. In the meantime, just before we start, if I can ask everybody to mute so that we don't hear whatever's going on in the background, the cats and dogs and whatever's happening in your home or wherever you are, and also to turn their videos off unless, except for myself and Professor Myers when he's ready and once we've introduced him, and then during the question and answer session. Okay, so if you can just give me a minute, I'm going to move people from my Teams meeting to this meeting, and then we'll get started. Okay, that's great. I can see that the people from our Teams room are starting to join. I've got my Teams open in the background, so I can let people know if there are others that join. So I think we can get started. It's great to see that we have so many people here already, and I think that's very appropriate because we're very excited today to welcome Emeritus Professor Jonny Myers, who is well known to many of us, a former head of the School of Public Health and Family Medicine, and I must say it feels quite surreal to be welcoming Jonny. Jonny taught me almost everything I know about epidemiology. I remember he was the convener of the advanced epidemiology course when I did my MPH many years ago. And I think Jonny thought he had retired, but he discovered at the beginning of 2020 that there was another new career for him to do. And that was to follow COVID stats very carefully, not only in South Africa, but around the world, and to start a WhatsApp group. And I think there's a Facebook page as well, but I'm not good at Facebook, where he shared his excellent analyses with people from across South Africa, but also internationally, and including many of the leading scientists in South Africa. And just as an example, I think it's fair to say that Professor Shabir Mahdi, who won the gold medal for the Academy of Science in South Africa, is just one of the many leading scientists and infectious disease clinicians and epidemiologists and public health people who are part of Jonny's group, and has really created a great space for exchange and thinking, which we commend him for, in addition to the excellent analyses that he's done. So I thought it would be great to ask him to join us today to share what many of us have been through, which is the steep COVID learning curve, and what he's learned. And I think many of us will sort of have had some similar experiences. So I think there'll be a lot of shared experiences, but also the incredible insights that he has developed along the way. So Jonny, over to you. I'm going to ask that everybody mutes except for Jonny, and also turns their videos off, and I'll shortly turn my video off. Jonny, if you can turn yours on and unmute yourself. Also, because we're a big meeting, I'm going to mute the chat until a little bit later when we get to the question stage. So I'm just going to keep the chat off so that we don't get too many distracting comments, and otherwise over to you. And Jonny will speak for about 40 minutes or so, and then hopefully we'll have some time for questions. Thanks so much.
Can you hear me okay?
We can, and we can see your screen.
Okay, thanks very much for those very kind words, Marianne. So I'm happy to be speaking here, and this is the topic, is climbing the COVID learning curve. As you can see, it looks something a little bit like a Clockwork gorge. Why am I not, is it not going down? Here we go. So, but I must stress it's by an amateur. I know that you gave me a glowing introduction, but I really am a bit of an amateur, and I thought I would just give you a little bit of very quick background. That my first encounter with epidemiology was back at the London School of Hygiene in 1977. There were no MPH courses at the time, and I did a course entitled Epidemiology and Medical Statistics, which was very, despite the tropical imprimatur of the school, it was a chronic disease epidemiology orientation, because that had displaced, of course, the infectious diseases of the 19th century. And to make matters worse, after that, I did a diploma in tropical medicine and hygiene, which also I should know much more than I do. So the chronic disease focus got worse for me because I got pushed into occupational epidemiology at an early stage. And that led to also an interest in environmental chronic disease epi. And these fields are very abstruse. You spend most of your time trying to unravel causal mechanisms. And you know, that's not always, you lose sight of what's actually going on from a health point of view. So I must also confess that I've never learned evolutionary theory. I've never understood genetics beyond Mendel. I've no immunology or virology or vaccinology. I've had to pick up everything along the way. And that's why, thank God, I've managed to get people on the WhatsApp group who really are expert and know what's going on. And then, of course, the hubris of modernity supervened. You know, we've had very optimistic authors, scientists like Steven Pinker, and historians like Yuval Harari, who have written about humanity's steadily improving condition, predicated on conquering infectious diseases, conquering hunger, and decreasing mortality from various forms of violence and warfare. And, you know, the strange thing is that here we all seem to be going backwards historically in time. So I've really ended up as an amateur in early 2020 in infectious disease epi. So that's just so much for background. And I guess a lot of people became instant epidemiologists during the course of the pandemic, and I'm sort of really one of them. I've had a bit of training, but that's, so now I just wanted to give you also a very brief word on theory and practice. Many years ago, in a previous life, I studied physics and mathematics in a BSc, and we used to share our physics classes with the engineers. We used to sit at the back looking slightly hungover in the mornings. And when things got a bit complicated mathematically, they'd shout, "Never mind the theory, just give us the formulas." So that's really what I'm going to do here. I'm going to give you some of the formulas. So I've been using, I think I've skipped a thing here previously. Let me just have a look. Yeah. So because I've really lacked a lot of theoretical grasp of these virological, immunological type of matters, and of course, mathematical modeling, I've ended up doing what epidemiologists usually do. They follow the data. And I've also become really reasonably competent with data over the years, with all of the teasing out the causal contributions to various sorts of abstruse diseases of occupation. In the course of this work with data, I discovered the Loess smoother, thanks to Mary Lou Thompson, who's my biostatistician collaborator. And this is a great way of smoothing data for data exploration when you're analyzing your results of your study. The raw data, of course, very jagged, and the conventional smoothing methods used are the 7-day moving averages, but those are also quite jagged. So I decided to use Loess, and I experimented with different sorts of bandwidth. So here you can see what I mean. The cyan here, the light blue, is the raw data. The dark blue is the 7-day moving average, and the red is my Loess smooth data, which has several advantages. For one thing, you don't have this noise. Why is this not giving me? Here we go. Sorry, it's not really taking my buttons. So it seems to have jumped. Sorry, I'll get used to this. Yeah, so the next one, you avoid the noise. And then even with the 7-day moving average, there's a lot of noise. You can't really see what's going on. These are just the sub-districts in the Western Cape Metro. But here you see them beautifully using this smoothing technique. And this is what I've really been used. Advantage is you can really see what's going on. You can compare the curves. And I think this is doing something weird for me. No, all right. And then, so that's basically, we get on to graphing. So having used that method, the other advantage is, the disadvantage is you get different estimates of peaks of waves and also the timing. So they're all slightly different depending on what sort of smoothing you use. That could be a bit of a hassle. But I also found strangely that this method of graphing was very sensitive to inflections, either upward inflections at the start of a new wave or when it was about to peak. It usually 7 to 10 days before the other methods, or that the top of the peak or the bottom of the trough were called. And here are just some graphs to show you. So these are South Africa and the 9 provinces, case rates and then death rates in the top row. And then for the Western Cape Metro, including rural and the metro sub-districts combined with South Africa in green, you see the same thing for the Western Cape Metro. And here are the sub-districts. The cases look beautifully symmetric. The deaths are not quite so symmetric. And then the cumulatives, those are the curves that we've been climbing. Here we go. And then some select Western European countries where these graphs show the case rates in dashed colors, and the death rates are all in the solid colors. This is just a mess, but you can still see what's going on. I mean, for example, blue is the UK, and you can see that what it's been doing, and I'm going to come back to that. I just want to give you a brief look. So here's the good. That's Portugal. Portugal vaccinated right at the end of last year. They had, after that, quite a substantial, they were before the peak of their wave. They had another wave afterwards, the third wave, and there's virtually no deaths. Death rate is completely flattened. And here we have it's going very strangely. And the not so good, as I had originally thought or hoped. And here we have Israel on the left, and you'll see that they had a massive wave, 2 actually, after they started vaccinating. The second vertical line is their booster program. And they've had quite a severe death wave post-vaccination, not quite as high as their second wave, which you see further back. And the UK is doing something very strange. Its infection rate has gone, case rate rather, has just gone up and up and up, although the death rate does look to be peaking, and they're very worried about it. For them, it's very high. They just aren't aware of our rates, and hopefully it's now declining. And then there's the bad. So this is America, USA. They vaccinated before the top of that third wave of theirs. They've had a massive 4th wave of cases, and they are on an upward incline, and they're probably going to exceed their last death wave as well. And although they're in the late 60s, they're 68 or 69% covered vaccine coverage nationally. So they're the bad. And then then we've got the ugly. Yeah. So the ugly I've got 2 examples here. This is Romania on the left and the Western Cape, that's us on the right. And I'm using these because my son lives in Romania. I always keep an eye on it. So they have only got 30% vaccine coverage, and you can see things are really out of control. They're heading into quite a bad wave in the middle of winter. And we, of course, just finished our wave, but we had a very severe third wave of both cases and deaths. So, and then I've also been able to look at other things. Here I'm looking at Scandinavia, which is a microcosm of very evolved countries very rarefied environment up there, but Sweden, you see, has done quite badly in relation to the others, but it's doing quite well in relation to countries like the UK or other Western European countries. And then I also looked at Asia. And, you know, Asia's been really quite mysterious, but if you look at the top panel here, top row, you see that first we had India, which had a massive wave, and then we had, and now more recently, we've got Thailand and Indonesia. And when you compare this, the purple thing on the right, the purple wave graph on the right is us, it's Western Cape. And you can see they're quite a bit below us as far as cases are concerned. And when it comes to deaths, the bottom row, we had very massive deaths in India initially, and then it got even worse with Indonesia, and then Vietnam suddenly appeared after being 0 cases for months and months and months, most of last year. And now you can see Singapore is going up, but in fact, the deaths are very small in relation compared to us, especially Singapore. The cases are going up, but there are no deaths. That's because they're fully vaccinated. Okay, so that's, I just wanted to show you what those graphs do. And now I'm going to talk a little bit about some memes that have been very common to the pandemic, and also some, so memes. Let's talk about memes. So firstly, there's been the testing mantra, particularly in the States. And then there's been an obsession with flattening the curve. There's been a complete fixation on immunity being humoral antibody responses, which are very difficult to measure. And when they are measured, it turns out you get very strange results. So during the epidemic, they seem to be at the height of the peaks, they seem to be quite low. And then so after some months, they seem to be low again. When they were measured at the peak, they were a bit higher, but never very high, and so on. And then there was the question of taking reported published data at face value for poor countries, which really took the form of, oh, you know, Africans are somehow immune, they're having a good pandemic. I'll come back to that. Then there was later on vaccination policy became completely fixated with total numbers, undifferentiated. And then we've had again a vaccination following the testing. And there's been also, apart from the fixation with numbers, total numbers, we've had developments around boosters, children needing to be vaccinated, and then of course mandatory vaccination. And these all are covered endlessly on the media, especially the television media, but more generally. But most of all, the real meme that's operated here is to follow the leaders, that everybody's followed the leaders. So in the beginning, they followed China and then Europe with lockdowns. And then for vaccination, especially children, boosters and mandates, we seem to be following the States, which is hardly a fantastic example to follow. So now I'll talk a little about these predictions. You know, predictions have abounded during the course of the pandemic, many that I've made myself and proved to be totally and utterly and embarrassingly wrong. And so there have been many surprises which have confounded. I use that in the English sense all the way through. And these are just some of the things I want to pass through. So the early predictions of mortality loss ranged from 44 to 88. That was the ASA prediction. And everybody thought that was incredibly high. And in fact, Panda was, you know, beating a path to the door of anybody who would listen that it's only going to be 10,000 deaths. And of course, at that stage, nobody thought there'd be more than one wave. Everybody was thinking about one wave. And they thought coronaviruses are seasonal, which our second wave showed wasn't the case, didn't come in winter. And then there were predictions about population immunity. That's also a mea culpa. I was completely wrong on that. Levels, of course, were measured. They appeared to be quite high in certain areas, but it depends on the type of immunity. So we've got the antibodies, we've got the cellular immunity, and then there's also the question of persistence. So this whole area suddenly became from something that I thought would be very simple in the beginning. Oh, you can just wait a while. When enough people have been infected, you can go and do a random population survey and you'll find out exactly what's what. But in fact, this has turned out to be very, very misleading and not at all a comforting situation, because as it is, this is a very hard pandemic to get a grip on because of what you can or what you can't measure. Then the variant suddenly appeared, and that was also, to me, very surprising. And those were the really big surprises. Of course, we had COVID denialism, which happens with all pandemics, I've discovered, going back to Edward Jenner, as well as vaccine skepticism. And, this was driven by increasingly now more recently by disappointing vaccine efficacy results against infection, asymptomatic, mild or moderate disease. In our case, that led to a tragic wasted opportunity to prevent severe disease, hospitalization and death in South Africa, which we could have done if we hadn't given our AstraZeneca away. And then we later on discovered there's good preservation for severe disease, hospitalization and death. But the vaccines increasingly became less effective for the infection, transmission, mild and moderate disease as the variants became more and more transmissible. So, and then lastly, the idea of herd immunity, which led in this epidemic with the approach of the UK and Netherlands, that whole idea has just sort of totally disappeared, at least in my mind. It's morphed into notions of the pandemic becoming endemic, what I call endemicity, and I'll take that up in a sec. So, yeah, so there are some more predictions. At one stage, they were talking about tweaking vaccines against now non-existent variants, beta. I don't know what's happened. It's all gone quiet as far as I can work out on that score. Booster doses of untweaked vaccines against the original virus are now being given, but can we really expect those to stop infections and transmission? I don't think so. And then, are the boosters for the vulnerable, or are they for all, for everybody, against this evidence? And there's the question of who do you vaccinate, vulnerables or all children? Do you use the risk-benefit gradient or approach? Since yesterday, we've been doing children in South Africa. But, if you look at the quality of subsequent immunity in, for example, the United Kingdom, where they've had very, very high rates of population vaccination coverage, yet there seem to be problems both with infections going very high and staying high, and also with deaths, increasing deaths. In people, a lot of those people, about 50%, are fully vaccinated as well. So what are the implications? Are we going to be stuck with having boosters ad infinitum every season? And how rational is all of that? And then the last thing is, where is evolution really taking us? Are we going to increase transmissibility? We've now discovered there's this AY 4.2 in the UK, despite previous studies that have shown that in countries that are more than 10% vaccinated, you don't get new variants. Well, that's just not the case now. Are we going for decreased virulence, which is the conventional wisdom, once enough people have been immunized? Or are we going for increased virulence? There's something that turns out I'll come back to that in a second. Or are we heading for an endemicity situation, or perhaps a flu-like epidemicity, so an epidemic every particular season? Sorry, I'm getting an incoming call, which I'm trying to get rid of. Okay, so now, very briefly, something about the historical comparison of the severity of COVID. I just want to say something about this. we know that in 1918, well, it's been estimated 50 million people were killed, but they didn't know too much then. You know, the causal agent didn't know about viruses. They didn't have good demographic data. The Economist now estimates that we're around 16 million dead based on excess deaths. So we're definitely up there with the big one, which I always thought this was going to be the big one. And then I did some comparisons, you know, the worst recent flu, when we've had good statistics, we've known the denominator, 45 million in the USA, 61,000 deaths. That was a bad epidemic in the States in recent times. If we compare that now, we're sitting at almost 730,000 deaths in the US. So that's really a whole order of magnitude higher than the worst flu. So I just wanted to mention that. Now, these are the, sorry, that just shows it, but I'm not going to waste time on that. Now I want to talk a little bit about data. Data of either availability or unavailability, both in the public domain and also perhaps private sector as well. So there's been very good data generally, I think, for certainly we think about the Western Cape dashboard. The national COVID dashboard has been good. The national vaccination dashboard is now very good. The MRC weekly excess deaths are really fantastic. I mean, that has really been the guideline through this whole epidemic, because those are the most incontrovertible data, the hardest data that we've got. But, you know, a lot of data in South Africa is just not available. Either it's not reliable. So outside of the Western Cape, there's very little that's available. You know, there's also data that we can't get from the public authorities, whether it's the NICD or the different health departments. It's just sort of not in the public domain. Johns Hopkins has been a fantastic site for global deaths. And so, can you fix this? I can't see. I need to. Sorry, beg your pardon. The global deaths, they've got everything, including us, all the countries there. And then there are various things you can look for, quick lookups. But the really interesting thing is the UK has got absolutely amazing data. So they are able to, firstly, they've got intensive care reports which come out weekly, and they show you exactly how bad things are, because you can see COVID admissions to intensive care units throughout the country. They also, their Office for National Statistics is also very, very good, and I'm going to show you some of those in a second. They show excess deaths, also deaths, underlying cause of deaths, as well as reported COVID deaths. And you need all three to really understand what's going on. But also, there are all these different methods, metrics rather, and I've now mentioned all of them. There are just one thing I wanted to say is that some of the South African data seems to have hit pop here, and there are administrative obstacles put in the way, or legal obstacles seemingly put in the way of getting data, certainly from National, who control the EVDS, to other health departments who really need it in order to be able to trace people who've got comorbidities, or perhaps only had one dose of the vaccine and haven't pitched for the second. And then the other thing that's really missing generally everywhere is aren't really age standardized rates, which really would be good, because age is the biggest risk factor for COVID, and age distributions vary really substantially. I'll just give you one example. The percentage of children in Israel is 23%, and it's 2.3% in Europe, just for example. So what are the data that we have got available? What are they telling us? And these are the things I was being interested in looking at. And I wanted to know, how are the provinces different? And then within the Western Cape Metro, how are the sub-districts different? And why are they different? And it turns out there are just so many mysteries to COVID. It's been difficult to untangle in a coherent way. But here are the raw numbers, which you see are not very useful because you don't know what you're comparing. You're just comparing absolute numbers. And we've got different sized provinces. So the rates are much better, and they will really tell you something. These are the excess deaths that I'm using here. And then, of course, the standardized, the provinces in South Africa fall into two categories. 5 are high, above the national average, which is in dark green here. And then there are 4 which are low, which fall below that national average. And of course, in the Western Cape, we are really a low outlier, which could be either good news or bad news. I think it's good news, and I think it's due to our excellent Department of Health and to our really, really very good services. But it could also mean that we have less immunity. So that's a bit of a double-edged sword. I've pointed out before that if you look at the case rates in the sub-districts, they're incredibly symmetric. And if you look at the cumulative rates, you'll see here that, again, the dark green is in the middle is the national rate. You see it, that the wealthier provinces are down here below, and the higher, the poorer provinces, more deprived, the sub-districts are above the average. So, and then we go back here to the Western Cape, and if you look at the death rates, you can see that Khayelitsha is doing something very different to all the others. All the others had a milder first wave, and then progressively worse second and third wave, whereas for Khayelitsha, it was the other way around. And my best explanation for that has always been, which is I've been following Khayelitsha very closely, that they had very high natural immunity from the first wave. They're a homogeneous population compared to Klipfontein, which is in the orange. And they were much higher than the other provinces. And at each wave, there's been more immunity of a natural sort to go around, and perhaps some more from vaccine-induced immunity for the third wave. And then you see it here in terms of cumulative mortality. They're the lowest, well, not quite the lowest, but yeah. So the two signals that come out of that for me is there's a clear socioeconomic gradient for severity of impact, but there's also the protective effect of natural immunity based on the impossibility of effective NPIs on population immunity in the most deprived sub-district. Now, following the science, what does that really mean? So I think there've been a lot of distortions in the global media, which often likes to say they're following the science, but really it turns out that there are different positions on many of these things. There's no real science per se. Of course, there is science, but there's scientific polarization, and there's also political polarization. And in places like the US, it's been particularly ugly to watch unfold. It's also very difficult to understand and evaluate studies judiciously. For example, we take the ivermectin issue. There are reams and reams of stuff. They're meta-analyses. And they're very difficult to understand because the measures they use are terribly derived. I mean, by the time you've got to those measures, you've lost any sort of real sense of what the actual data really look like. Then there's mathematical modeling, which has also, for me, been very difficult to follow. I've got some understanding of maths, but it's not fantastic. And also, the models have often not been accurate, not their fault. I mean, as I say, this has been a pandemic full of surprises. Then there's been some very clever people on the anti-vax end of the spectrum. And, you know, I spent hours and days trying to get my head around some of the arguments that I've come across on YouTube. Some of them are very complex and very beguiling. And sometimes one doesn't understand them in the beginning, and you only come to understanding a lot later as to what criticisms can be mounted. Anyway, so I think, but for the real hardline anti-vaxxers, persuasion and logic seemed to be ineffective. And then for the vaccine hesitant, unfortunately, there seem to be some forced errors and some unforced errors. And here epidemiology is useful. And I'm thinking here particularly for explaining paradoxes. So one of the big paradoxes was in Israel, they found that 54% of all the people in the ICU were fully vaccinated as opposed, and everybody, sort of almost everybody was vaccinated. So what was going on? The vaccine's not working. Turned out this was a case of Simpson's paradox, which I'm going to come back to. But essentially the vaccine efficacy was sustained. It was preserved despite the seeming preponderance of fully vaccinated people with COVID in the ICUs. Then there's also the need for truthfulness. You can see that people tend to suppress uncomfortable findings, and they've got a lot vested in the studies they're doing. And when they talk about them in the media, they often gloss over issues like side effects and this and that and so on. So, I mean, it's understandable, but it becomes a feeder for resistance. And then, of course, there's the resort to the primeval responses that are so typical of all of us primates. Our neural networks, all the stuff is baked in. Basically, conspiracy theories you need in order to understand and negotiate the world. The people who are unvaccinated or unclean, their draconian policies, krachtdadige mandates, and so on. So this all feeds hesitancy in the perverse type of a way. Now, what about the truth of what is it that kills? Is it COVID or is it lockdown related? And this has been argued very cleverly by lots of people to cast doubt on the existence of the pandemic. But the UK graphs are fantastic. They really enable us to disentangle all of the stuff. So one of the things that was very counterintuitive when I first heard it was that there's a general decline in expected mortality in states of crisis. And that's exactly what happened here. In fact, the MRC had to adjust their expectation baseline lower than it would otherwise have been. There's the question of, what is excess deaths? I mean, we know, thank goodness, from the Western Cape, from the good quality data, that most of those, 85, 90%, have been COVID deaths. That's because we've got good data. But in a lot of other places, you don't have good data. And then there are all these claims. Well, it's actually due to people who can't get to the health services to get treated for their heart attack or their cancer or HIV, and they're all dying like flies, and that's what's giving you excess deaths, and we're not seeing. So you need all three of these things. You need excess deaths, expected cause-specific deaths, and you need reported COVID deaths. And we, of course, don't have this. We only got two. We've got excess and reported. The UK's got the rest. Let me show you what I mean. So here, this is looking at we're looking here at acute respiratory deaths, which would be flu and other causes. Flu's been a bit absent, but nevertheless, you can see that here, just the dark gray, throughout the entire pandemic. Look how low these deaths have been. And here's the purple is the expectation line, and above the expectation line, it's all COVID. The orange is COVID. So COVID here is responsible for the excess deaths, which you see in the upper panel, almost entirely. Totally entirely. And then you can look at this for some others. Ischemic heart disease, it's the same thing. What's sitting above the expectation line? It's a few other causes, but it's mainly COVID. And there's been actually a decline from expectation of deaths from ischemic heart disease, and so on. It's true for cancer. So just to make that point. Now, I wanted to come to some of the mysteries. In the beginning, there was this whole thing about COVID and Africa. That Africa's having not a bad epidemic, but in fact, if we used Western Cape as a proxy for the least severe scenario for South Africa approaching the truth, nevertheless, we were right up there with the worst in the rich world. So these were sort of early battles to try and get people to because everybody just accepted this. Oh, yeah, there's something magical or mysterious about protective factor. Just look at this. These are, here with the black is the Western Cape, and that's low because South Africa generally would be much higher than that. And here are all the others. So the Brazil is also up there, but for the Western European countries, the UK was way below South Africa, as was the USA. So just the point I wanted to make. So the next question was, do NPIs work? And, you know, these are not things that you can test through controlled studies. And obviously there's a lot of urgency to all of this sort of stuff. But if you look at our graph, and I think I've got it here. No, I don't have it here. But I'll show the graph a little bit later. If you look at the timing of NPIs, of the different levels of increase and decrease in our levels of lockdown, and you look at it on the graph of the different waves, it's not at all clear that our lockdowns had anything to do with the behavior of the waves. So that's the next mystery. These waves, why do we have them? What are their dynamics? Why do they rise? Why do they fall? And why with such clockwork regularity? Yeah, here, this is the graph I was looking for. This is like clockwork. You know, this is something almost like something that's been pre-designed. The peaks are exactly, well, not this last one, but if you look at the actual raw data, the peaks are more or less equidistant 6 monthly. And there's this sort of quite a brief gap, a month or two, in which it stops declining and then starts rising again pretty quickly. And it just doesn't look as if any of these things, except for possibly the third wave, where we got in early, but everywhere else we started to get in a lot later than too late to really do much to flatten any of those. So then the other thing is the mystery of the variants. So are the variants a necessary driver for waves, or are they just what I call a maniacal driver? They really drive those waves up viciously. And the sub-question is, can we get an even more transmissible variant than Delta? Last week, there was quite a bit of discussion that no, you can't do that. We can't do it because the virus is like somehow reaching its limit and it's unlikely. And the question then was, if we didn't get a new variant, can we still have another curve, another wave? But now this week we hear about AY.4.2 in the UK, and that's clearly driving another wave in the UK. If you look at the shape of their case rates curve. So can the variants also now can they be more virulent? And will further mutation under selection pressure from both natural and vaccine-induced immunity lead to a lower virulence? So that's the common perception. And then we get manageable endemicity. Or might this lead, in the presence of prolonged periods of high case rates, despite vaccination, full coverage, to increased virulence and more severe disease over time? And there's a precedent for this. It's called Murek's disease. It's a disease of poultry, not of humans. But the principle is there, and that's possibly a frightening prospect. Or even worse, will there be a mutation for vaccine escape for severe disease, hospitalization, and death? So these are all mysteries. We've got, I don't think, any idea as to a firm idea as to what's going to happen. So we've had the vaccine performance issues. See, I'm coming now to the end of my time, so I'm just going to go quickly. But there have been several issues, and I want to just discuss the main issue, which is a leaky vaccine. COVID-19 vaccines are leaky. They allow infection, breakthrough infection, so-called, but it's at hell of a high rates, probably greater than 50% of people who are fully vaccinated. And they, and they also are so far protective against the severe effects. So I'm going to skip over the rest of that. And here's the schematic for a leaky vaccine. So here's the population of pathogen. You give the vaccine at the red dot, and what happens is it crimps the population expansion, And all of this happens below the black dotted line here, which is the threshold for transmission. That's the perfect vaccine. We don't have it. This line is right up here above the transmission threshold. So we have a leaky vaccine. So to sort of get now to the end, I think, you know, I feel I've been humbled several times by COVID. I think first on the initial estimates of mortality, the one wave issue, the population immunity levels, which I thought I understood at one point, and I didn't really. Herd immunity, which I've now sort of discarded as a useful concept for this particular virus. The belief that vaccinations will set us free. I think the UK shows that's not the case. Vaccination targets started off good here, going for the vulnerables, but then it's rapidly dropped the age floor, and I'm not sure whether we're going to meet any targets at all. We've got the leaky vaccine, and then we've got these examples. I already mentioned Simpson's paradox in relation to the Israeli preponderance, but in fact, the Western Cape government put out a graphic showing that I think 99% of people who died were all unvaccinated. But that's the reverse Simpson's paradox. That's because there's so little vaccination coverage in the population. So I actually did the figures and I recalculated and I found a vaccine efficacy. It wasn't great. It was somewhere in the late 60%. And I understand that's due to the comparison population, but I won't go into those details. But it's not 99, it's not, yeah. So what I'm saying is it tends to overestimate if you look at it in a situation like ours as to how effective the vaccines are. They're actually less effective, slightly than that. And then what's going to happen in the Northern Hemisphere this winter? Already there's signs. Some of the countries are starting to go up again after having been very low. And what's going to happen here? And where are we going? How should we direct ourselves? So I think we need to keep an eye on the following countries. We've got to follow the rich countries, not to follow the leader, not to do exactly what they're doing, but to get a sense of what is happening, what we might be, because that's our future at some level, if we ever get to a decent level of vaccine coverage. We've got to also look at the paranoid countries, these second world countries like Romania, who are so suspicious of government post the communist era that people they don't want to listen to any messages coming from the government. And then there's the poor ones in the third world where we just don't know what's going on, no data. And of course, we can also look at the zero world countries, Australia and New Zealand, where I think they've dodged the bullet. I've been up and down on that. At one stage, I thought they were quite crazy. At other stage, I thought they were going to run into problems with anti-vax sentiment, but looks like they've dodged the bullet. And we've also got to look closely at the USA, because I think that could be our sort of future. And I think I've covered most of these things. Yeah, and just the targets. I think that if we can get by the end of the year, more than 90% of our over 50s fully vaccinated, we can expect to have a flattish death curve. But I don't know if we're going to get there. That's the problem. And if we don't, we're going to have, I think, a fairly bad wave, unless, as Donald Trump says, the virus just goes away. And here's my last slide. So this is just to look to the future. I think we can probably expect a peak with the solid red line on the right, somewhere around late January, February, and it'll start to go up somewhere around late December, if what has been happening before is going to carry on happening. Thanks.
Thank you so much, Jonny. I think that was a real tour de force of a journey that many of us have traveled in many ways. But amazing to hear your insights, and thank you also for being brave enough to let us have a look into your crystal ball at the end. We've got a big audience. I'm going to open the chat for questions, and I'm also going to invite people who may want to comment, if you can raise your hands or unmute. I see, Rodney, you've unmuted. I don't know if that means you want to ask a question.
Yes, if I may. That was rather brilliant, Jonny. So your entry into real time from chronic disease is quite interesting, because while the pandemic may not be unique, the amount of information, the speed of transmission of new information must be unique. So you're also in a type of cyberspace, and because you don't sleep, you have been following it more or less in real time. So my question is this: is there, well, clearly for many countries, there just simply isn't enough information. But for the other countries that do produce a lot of information, is there enough information? Is there too much information to handle, in the sense of being able to affect the course corrections that are needed? Because information has to be processed administratively, bureaucratically, and then politically. So, and you've been watching it at all levels. So I'd just be interested in your comment on that.
Too much information. That's what
to manage. Too much information to manage, to be able to correct course. Yeah.
You see, I think there's some critical information that you need. And I mean, a lot of the information that is, you only need a few variables really to be following. I mean, for example, one of those now, I mean, I think the province, and this is in Mary-Anne, some of your fantastic presentations, you have this graph where you've got all sorts of indicators of what's going on, which are, I think you use to work out when things are peaking or getting to the trough. You only need one or two of those things. And, in a sense, I've really chosen to look at I'm really interested only in excess deaths, to tell you the truth, generally, when we're talking about comparisons. But now in the vaccination era, there's another one, you see, and I think that there's very precise information on that, but it's not, up to quite recently, it wasn't getting out. And I think this is a huge problem. I think that there is a national tendency in most countries, but I think it's very strong here, to control everything. And I mean, in a sense that, the national department should be a servant of the provincial departments, who already have they're responsible for health. And there shouldn't be any barriers. People should really be able to be connected but take advantage of that. So I think that's one thing we don't have, unfortunately. As I understand it, only our province had a link to EVDS, and that link has been broken for a month. No clear reasons for that. I don't know if that answers your question.
Thanks, Jonny. I see someone called JP had unmuted. I'm not sure if that meant you wanted to ask a question. But otherwise, Pancho, who's one of our former MPH students.
Is that JP Panikirk? It's probably
probably, yeah.
Previous dean.
Yes, probably.
It'd be interesting to hear what he says.
I can ask him to unmute. Let's see. Okay, I'm not seeming to have success, but JP, if you have a question, please come in. So Pancho Molongeni, who did the infectious disease epi module with me a few years ago, has a question. Pancho, please go ahead.
Thank you so much. I want to privilege. I wanted to ask, can you please explain again really why Israel's data is a case of
this is not intelligible. Maybe you could, not intelligible.
Pancho, your connection is not great. I'm wondering if you can type your question in the chat, because it's really difficult to hear.
Oh.
So I think if you just type your question in the chat, then we can try to address that.
Hello, I wonder if I can be heard.
Yes, we can hear.
Hi, yes. Thank you so much.
No, sorry, it's still not working, Pancho. I'm sorry. It's just very Yeah, not a great connection, and you sound far away and you're speaking very slowly, so we can't actually understand. Perhaps while we wait for Pancho's question, I can just comment in terms of the issue of most of the Simpsons paradox issue, and most of the people in the Western Cape being unvaccinated in the Western Cape infographics, which I completely agree with, and in fact was very resistant to put those out for a long time, because I said, what are we going to tell people in 3 months' time if our vaccination program actually does get high coverage, and then everybody in the ICU and everybody who dies will be vaccinated, because everybody is vaccinated, and how we're going to explain this to people. So I think it is, you know, what has been very challenging, certainly for me, is striking the balance between communication that works and but is also accessible to people without an epidemiological or a scientific background. Jonny, I don't know if you have any comments on that in terms of best ways to communicate. So someone who's followed so much of what's out there in the public domain, the best way to communicate what we are learning in order to help people to be informed.
You know, not really. I was myself taken in by that graphic as well at the time. So, you know, it's just, these things are very difficult to explain. And I think the Premier's, what is it, when he talks to the
Digicon.
Yeah, the Digicon. Yeah. I think generally the information is very good that's being put out. I just think that it's hard to find a way of explaining a lot of these epidemiological concepts. They're incredibly slippery. In fact, I had to remind myself. At first, I didn't know what's, you know, we don't use the term Simpson's paradox. It's just a handy sort of a handle. But of course, what it's all about is it's about aggregation and disaggregation of data, and how you can get, you know, considerable, it's really confounding bias, basically. And, you know, I found a very nice little clip on YouTube that I sent to a colleague, but the colleague was, you know, an infectious disease expert. So it's and then he understood it when he saw this little video. So I think some things are just very difficult to explain. And I wouldn't have a great answer to that. You'd have to, if somebody came to you and they said, look, why is it that such a high proportion of people in your ICU or who have died were fully vaccinated? You would have to sit down with them and explain that the vaccine isn't 100%, and that there are, as you've said, that if everybody's covered in the population, the only people who can die are the vaccinated. But, you know, it involves some sort of personal, I think, explanation.
Thanks, and I think that's what we're learning so much as in terms of particularly the vaccine hesitant, is this, you know, the huge importance of personal conversations, which I think is, you know, something that is so important for all of us to learn, in terms of, we can put all the information we want out in the public domain, but it's those personal conversations that matter. I don't see any questions in the chat. I'm just going to have a quick look. No, there are some. Let me just see if I can go there. Virginia has asked, besides vaccination, what strategies have you found that have decreased excess death? And that could, I guess, be implemented in our setting, given that things like what New Zealand has done is not a possibility for us. I don't know if that seems like a very challenging question.
Yeah, I couldn't answer the first part of that. Strategies that decrease excess, I don't quite understand that. Yeah, no, I don't understand Virginia's question. I'm sorry, Virginia. What is
Virginia, I don't know if you want to unmute and ask your question.
Yeah, thanks. So Jonny, my question is really what interventions could work to decrease the impact of COVID on our society? And you've identified excess deaths as a main metric that we need to follow. So, you know, you're looking at the good, the bad, and the in between. Are there any initiatives that some of those countries have implemented that would that we could learn from for our epidemic moving forward? That's really what I want to ask.
Okay, no, that I can answer. Look, I think it's very clear that we have to adopt strategies that will limit transmission of the virus in the current situation with the leaky vaccines that we've got. So as a colleague of mine on the group from the UK has been arguing persistently, we definitely are still in need of these NPIs, not lockdown necessarily, but I think quite fairly strict controls in confined spaces, indoor spaces, and you know, masking up and all that sort of stuff. We still need those, and that's, I think that would. And Australia and New Zealand are also going to need those, because I think New Zealand is now battling with a runaway infection of the Delta variant. And they're going to, the only way that they're going to keep that under, they're very, I think, highly vaccinated, they're going to have NPIs. And the other countries are going to have to reintroduce them, like Denmark and the Netherlands and so on.
But Jonny, in the context that we live, with people living in very overcrowded dwellings, going to work in taxis, where social distancing and good ventilation are not really possible or taken seriously. I mean, the masks are not hugely effective. Are we just going to have to learn to live with this and just sort of carry on and try and protect the elderly and the people most at risk? Yeah.
Yes, look, I'm hoping that Khayelitsha is a sort of is a pattern for that. I'm hoping that already we've had such, you know, runaway infection in areas where NPRs are not possible, that there will be heightened natural immunity to complement vaccine-induced immunity. But clearly there's, you know, there are limits to what you can do there in our sort of society. And, you know, I think that's just what you can't do, you can't do.
Thanks. I know, I mean, one of the ways we've been thinking about Khayelitsha is that they probably did continue to have infections in wave 2 and 3. We didn't know about them necessarily because they weren't diagnosed, but there's probably been not just one bad wave, but potentially, you know, multiple episodes of boosting that have happened in those kinds of communities. And I think, I mean, there's also data now emerging to show the substantial boosting of your immunity if you get infected post-vaccine. And so, you know, I mean, I don't know what the answer is, just as you don't have COVID has humbled us, but, you know, whether actually on our pathway to endemicity, allowing infections to happen while protecting the vulnerable, you know, might be part of the solution, because, you know, if people are protected, but by this leaky vaccine.
Yes, no, I would agree with that completely.
Thanks. I think there's a couple of comments in the chat. Andrew says, is it a policy objective to limit transmission? So he sort of echoed what I've said, when most transmission is on top of prior infection or vaccination. And this question around antiviral medication, and obviously the new antiviral that has emerged, and whether that on top could limit our mortality. So that's also in the chat, just to note. There was a last question, which I think we'll address, and we are over time. So I'll take this as the last question, which is, why do you think the reason for the African catastrophe that was initially predicted didn't come to fruition? And they're talking particularly of East and West Africa, because I think for South Africa, we have had a catastrophe. There's no doubt about it. In fact, I was just reading yesterday that our life expectancy has dropped, and you only usually see those kinds of things happening in a war. And so we have been through the equivalent of a war. But I don't know if you want to comment on East and West Africa.
You know, I don't know what's going on there, because I've never seen any data that I can make any sense out of. And I would somehow be surprised. You know, it may be that South Africa is more densely populated, the population as a whole is more densely concentrated in certain areas and so on. But I would be surprised if West and Eastern African countries were not quite seriously affected by this. But I can't get a handle on any data that are reliable.
Yeah, thanks. So I want to end with Sue Cleary's comment in the chat, which is saying, thanks so much for a fascinating presentation. And Jonny, I think we all really appreciate the humility, because we've all felt the same in terms of when people ask me what's going to happen, I say, well, I've got it wrong 3 times before, so I don't know why you keep asking me. But also for the WhatsApp group, which is incredible in its interdisciplinarity. And I think this pandemic has really shown us is the importance of that interdisciplinarity. And as we are all learning, just as you were, without those backgrounds that you mentioned in vaccinology or immunology, the ability for people from different backgrounds to come together in this pandemic and to learn from each other has been incredible. And I think your WhatsApp group has really facilitated that, largely within the country, but also with people from outside the country, which has been amazing to have. And even I know for myself, I don't always follow everything every day, but when one dips in to suddenly there's just this wealth of knowledge and wealth of people all acknowledging their humility, but open to discussing and learning from each other. So I think all credit to you. Thank you so much. Thanks everyone for joining. I think you'll all agree with me that this has really been a fantastic opportunity for all of us to reflect on the last 20 months or so, but also to learn and think about the way forward. And yeah, we look forward to your continued musings, Jonny, and teaching us as we go.
Thank you very much for inviting me. Thanks.
Thanks. Bye.
Bye. I'm not sure.